Thank you very much, Omnicuris, for giving me this opportunity. Ladies and gentlemen, let us have the talk today on coronary calcification and how do we manage that. So I'm Dr. Sharad Chandra. I was the editor of Indian Heart Journal in the years 2012 to 14, and I was president of Cardiological Society of India in the year 2018. I live and work in Hyderabad. So the title of today's talk is Coronary Calcification, How to Manage. Day in and out, we see cases of PCI wherein we encounter coronary calcification. The reason for this increasing incidence is because of an aging population. As you all know, the average age of population all over the world, and along with that in India too, the population is aging, and for this very reason, it is very likely, and it is more than likely, that you encounter calcification of the coronary arteries. The other important reason is the increasing incidence of diabetes mellitus, which also tends to produce coronary calcification, rather vascular calcification, and also CKD, which is also rising in its incidence in the society. Now, vascular classification, you can see biological calcifications. If it is physiologic, it is bone. Pathologic or ectopic calcification can be in the soft tissues or cartilages. It can be cardiovascular. And inside that, one can see that it can be valvular calcification, like you see in aortic valve when you encounter a patient with in a older age. It could be also in the vascular territory. It could be intima based, which is usually due to atherosclerosis. It could be media based, which is usually due to diabetes or chronic renal disease, and of course, very importantly, associated hypertension. So, putting it in another way, arterial calcification can be intimal calcification, which is predominantly due to atherosclerosis, that can lead to stenosis or occlusion of the coronary artery, may lead to infarction or ischemia. It could be medial calcification, which is usually due to arteriosclerosis, and this can lead to stiffening. There can be an increase in systolic pressure and pulse pressure and early return of wave reflections, all that you know very well. There is, of course, an important contribution in terms of left ventricular hypertrophy. Prevalence of coronary artery calcification, as I mentioned earlier, the coronary artery calcification continues to increase in prevalence in parallel with an aging patient population and rising rates of diabetes and renal disease. Studies have shown around 18% of patients undergoing PCI have moderate to severe calcification. Probably this figure is from a Western study. Our patients are not that old as on today, but even then, we do encounter coronary calcification quite commonly. Coronary artery calcification, a marker of future cardiovascular events, is a major challenge for achieving successful PCI result, because by a variety of mechanisms, there can be difficulty in either stent delivery or stent expansion, about which we are going to talk very soon. You can see here that these are images on OCT. On the left side, you see deep calcium. In the center, you see a calcified nodule, an atheroma that has become calcified and formed a nodule. And on the right side, you see superficial calcium in this OCT image. Complications of calcified lesions. Why are we so much concerned about calcified lesions? We are concerned about it because it can lead to a number of difficulties while doing PCI. This can make the balloon produce dissection at the ends of the balloon, because in the center, the balloon does not expand due to excessive calcium. And since when that happens, as you increase the pressure to open up the lesion, the edges of the balloon usually will open up more, and there it can produce dissection. So proneness for dissection is one of the important problems with this. And that may lead you to put one or two more stents than what is required. Then there is a difficulty to completely dilate. The same thing, it stretches into the same thing, that the lesion may not be completely dilatable. And that's why the experienced operators say that when you suspect a lesion is calcified, even if you are not doing an intracoronary imaging or in very old people, always it is better to dilate the lesion first to get a feel of the lesion and not do direct stenting, however tempting it is, especially in patients who are on the older side, more than say 70 years of age. The coronary calcification can prevent adequate stent expansion. It's the same thing that the stent, because of its excess burden and the calcification which offers resistance to the expansion of the balloon, may not allow the stent to expand, and when the stent does not expand adequately, that can lead to higher incidence of either stent thrombosis or stent restenosis. And another important thing is the balloon may go there and expand the lesion, but the stent may not be delivered there because there can be a calcific spicule that is projecting into the coronary artery, and there can be difficulty in delivering the stent, and you will be forced to put one more wire, what we call a putty wire, and do further dilatation at the point where the stent is refusing to go inside, and do all sorts of things to deliver the stent catheter. So all these difficulties can occur in of significant calcium. Effect of calcium calcification on PCI. Excess coronary calcium measured by CT is associated with a higher rate of unsuccessful PCI. The same thing. The presence of severe coronary calcification assessed by angiography in patients with acute coronary syndrome is associated with higher rates of cardiac death, ischemic TLR, and instant thrombosis at 1 year follow-up. Now, this is an interesting slide. You can see here, there are on the x-axis in each of these pictures is the number of years from the baseline examination. And on the y-axis, it could be cumulative incidence of CVD or cumulative incidence of coronary events, or in the bottom panel, stroke or a combined incidence of stroke or TIA. And inside this, you can see that for each quartile of coronary calcification, the incidence of these events increases markedly. And if it comes to stroke and stroke TIA, the difference between the levels is relatively limited. But as for coronary events or cardiovascular events, you can see there is a huge increase in the event rate when the coronary calcification is more than 400 score on CT scoring of calcium. Now, this is also an important information. Here you can see that when you have these 4 quartiles of coronary calcification, inside each one, they have subdivided the event rates according to the presence of neither metabolic syndrome or diabetes, only metabolic syndrome, or only diabetes, full-fledged diabetes. Here you can see the annual event rates are significantly higher when it comes to the presence of diabetes, even inside these 4 quartiles. So this shows the importance of the associated risk factors like diabetes and the interaction between diabetes or metabolic syndrome and calcification of the coronary arteries. Calcium cascade, this absence of intravascular imaging. It is ideal to do intravascular imaging today. With so much of knowledge, we know we have a lot of knowledge that intravascular imaging contributes significantly to avoiding complications and for a successful PCI. But in a given case, if you are not doing intravascular imaging and there is underestimation of calcium, there is increased likelihood of improper vessel preparation. You don't know that there is calcium. You obviously do it in a casual manner. You may not even dilate. You may do a direct stenting, or if you dilate also, you may just dilate it with a small size balloon. And with this, if there is significant calcium there, that can lead to improper vessel preparation, bed preparation, and that can lead to stent underexpansion, increase the risk of complications, longer procedures, stent malposition. You may have to do more stents. Now, options for calcified lesions. Now, there are multiple options to tackle the calcified lesions in coronary arteries. Now, there are rotablation, rotational atherectomy, what we call. This is there for a very long time. I remember doing the first case of rotational atherectomy way back in something like 97 or so. And orbital atherectomy has come relatively recently. I'm not sure this has received permission at this point of time. Intravascular lithotripsy is, of course, being done very frequently in India. Laser-based techniques, a laser catheter has also received permission from the government to be used in India, and the first few cases have been done, and modified balloon techniques. Out of this, the orbital atherectomy and laser-based techniques are out of scope for today's discussion, and I'll be concentrating on rotational atherectomy, intravascular lithotripsy, and modified balloon techniques for want of time. Now, this is an interesting case which I have done relatively recently, and this is a 50-year-old man. He's a diabetic for a long time. He came to us with angina for the last few days, but in addition, he has a diabetic foot with severe infection there. Because of his acute coronary syndrome-like presentation, we were forced to do coronary angiography for him, even in the presence of his infected foot. And you can see here that the coronary artery is having, the right coronary is having a long lesion and very critically narrowed in the middle. So for me, if you see carefully here, you can see that there's a considerable calcium right at the site of the lesion as well as proximal to that. So in this case, with such a long lesion, the obvious option is rotational atherectomy. Rotational atherectomy has been there for a while and people have considerable experience with it. And whenever I feel, whenever there is a long lesion with dense calcium, this is one of the best techniques to do. Now you can see here that the rotational atherectomy burr is going inside and it is just touching the level of where the tightest lesion is present. And this is a long recording. And you can see here, it has not yet crossed the tightest point of the lesion. It is just making an attempt. Okay. Now, this here, it has entered the tightest point of the lesion. And you can see here that it's going backwards and forwards. Yes, it has crossed the tightest point and it has almost reached the normal level of a relatively normal segment of the coronary artery. What is important, there are certain precautions to be taken while doing rotational atherectomy. We are going to look at them a little more in detail. You can see here that the rota burr is going rather freely now. And let's see the next one. Yes, the injection shows that quite a considerable ablation of the atheroma has occurred. It may not impress you visually very significantly because you have used only one burr, but in case like this, even this degree of surface cutting with using this atheroma, using this burr, it is more than adequate. You can see here, we of course had to use considerable. You can see here the lower part of it, there is a marker here, and this marker is the marker on the microcatheter. I always insist that we pass the balloon, we pass the microcatheter into the coronary artery, the point where we want it beyond the lesion, with the help of a routine wire, and then exchange that wire with a rota wire, because the rota wire is not an easy wire to manipulate. It's quite a difficult wire. It is very thin, and secondly, it somehow does not have the degree of mobility and ability to move the tip as you have it in the standard wires like a BMW wire. Therefore, I always insist that we take a microcatheter for putting in the rota wire, and we again take the microcatheter for removing it when you are going to put it. So after putting this microcatheter, we remove the rota wire and we put the routine wire after this. And the rest of the story is like any other angioplasty. Of course, it required a considerable dilatation of this atheroma. You can still see there is some degree of higher pressure required here, and it took some time to open it. And you can see now it has opened, and it opened something like at 12 atmospheres. We did a thorough dilatation of the coronary artery after this. And the two stents have been placed you can see this is the final result. 2 3mm stents, each one about 30 to 40 millimeters length has been placed in this. The patient did very well. He also had a disease on the left side, left coronary artery also in LAD, which also we did angioplasty. Okay, so after showing you this interesting case, let me take you through some of the important precautions and steps while doing rotational atherectomy. There are different protocols for rotational atherectomy. They have been investigated. Would you want to just pass a burr and remove it and then put a stent there, or would you want to do ablation thoroughly with it and be satisfied with it and no need of should it be the definitive procedure itself? There's a lot of discussion on this, but now everybody agrees the rota should be used for passing a drug-eluting stent there, because it is very clear that if once you put a stent there after rotational atherectomy, the event rates are considerably reduced and it gives better results. Now, particular attention has been paid to burr size. What is the size of the burr you will take? What is the rotablation speed and the motion pattern of the burr? Now, let us discuss some of these things. The idea of using rotablation is for modification of the plaque. It improves the plaque and vessel compliance, and it allows you to do the PCI in a better way in difficult situations. Now, there are two types of wires, rota floppy wire and rota extra support wire. Now, I always use a rota floppy wire. It is easy to do, and you really, once you have taken the rota burr, it is very easy to go across a lesion, and you really don't need a great support for it. There are people who argue and then they say that it is good to use an extra support wire. Opinion can be different. A stiffer guide wire does not always produce an unfavorable bias, but it can produce that. Now, see this here. In cases where the rota wire cannot be advanced past the lesion, a conventional angioplasty wire with an exchange microcatheter can be used. This point I already elucidated to, that it is probably an easy way of doing. It takes a little extra time and a little extra contrast, but it is worth it. The rota wire can be spoiled, can be damaged if you try to pass the rota wire across a lesion. It is always good to take a microcatheter with a conventional wire, go beyond the lesion and remove the wire, pass the rota wire, and again do the same thing when you remove the rota wire at the end of the rotational atherectomy. So this is an important point in my opinion. Rotational wire, be careful of guide wire loops that may form in the aorta. When you are passing the rota burr while the wire is there, sometimes the wire may form a loop. So that's why experienced operators always keep the guiding catheter in vision. You concentrate on the point of entry into the coronary artery and the point of ending of the guiding catheter, so that you will catch a loop of a rota wire that may accidentally follow, that may accidentally happen. So that, if that happens, the rota burr, as it goes across that, it will pull out the rota wire, or it will make the loop bigger and bigger, and you will be wondering what is happening to it. So it is always important to visualize the ostium of the coronary artery, place the guiding catheter securely in the ostium of the coronary artery, and then take the rota burr on that. Now you can see here, this is the wire clip torquer. This is a torquer on the rota wire, which it enters from the side. That is the speciality of this bar. Now, actually, although it is called the torquer, we rarely use it for torquing. We always use a microcatheter to put the wire inside. So what this does, the idea of this wire clip torquer is to hold the wire powerfully and carefully so that it does not rotate when the rota burring takes place. The rota is a very high speed burr. It goes up to as high as 1.5 lakhs or 1.6 lakhs per minute, and therefore it can rotate the wire, and we don't want that to happen. The wire, if it rotates, it can go more distally. It may land in a very small branch of the vessel, and it may produce perforation. So for all these reasons, you need to hold the wire very stiffly, and one person has to dedicate himself or herself to holding this with one hand. So this is the purpose of this particular thing, intended to prevent guide wire from spinning when brake defeat is activated. Actually, the rota console, what it does is, when you are activating the rotational burr from spinning, there is automatically a brake that is applied. But this brake sometimes may not be enough. That is one way. That's one reason for applying this torquer. But more than this, when you do what is called a dyna gliding, where you pass the rota burr inside through the guiding catheter, and it is not going easily, you have gone on a slightly higher speed from 0, let us say 50,000 or so, that is slow for a rotational atherectomy. Then if the brake is applied, how will this move forward? So you need to hold the wire and first break the brake. What we call brake defeat has to be activated. You can see here, there is a small black button on this that has to be pressed, so that the wire is still, the rota burr actually is allowed to move on this wire. And you are afraid that once again it may rotate, therefore you need to hold this clip. Now, 4 important lines are mentioned, what is called the DRAW, pre-procedure test: drip, rotate, advancer, and wire. There should be always a saline drip from the bottom of the advancer and catheter. Anybody amongst you who has seen a rotational atherectomy being done, there is always a saline along with some anti-G, which is flowing continuously through this. It is very, very important, so that it keeps the wire in a lubricated way, and over that the burr goes easily. And the other points I'm going to show you just now, you can see here the saline drip should be always flowing. In addition to this saline drip, I would also insist that the 3-port where it is there, instead of injecting contrast continuously, take some 50 ml syringe, fill it up with saline, and continuously inject it. Your assistant should continuously inject it while you are doing rotational atherectomy. So you get some saline drip by the side of the burr, and you also get saline infusion into the coronary artery. That would make it safest as far prevention of no reflow phenomena is concerned, because no reflow is an issue with the rotational atherectomy. In fact, the first idea of no reflow or slow flow has come from the experience of rotational atherectomy. That's the importance of it. So never operate the rotablator advancer without saline infusion. That's a very important rule to be followed in this. Now, the burr is rotating and you need to look at the RPMs. This RPM should be stable. If you have it, let us say 1,50,000, you have set it. When you go and actually ablate the atheroma, there is a slight fall. That fall should not be more than 5,000. If it falls more than 5,000, that means you are pushing it a little more than required, more forcefully than required, and you should stop it at that point. Take time, ablate it again, and do it. So it is important to see that from your presumed or expected speed of the burring, it should not fall more than say 5,000 to 6,000 than what it should be. If you do it more than that, that means you are doing some damage to the atheroma. Now, advancer, free movement of the advancer knob is important. There is a knob here which is holding in this picture, and that knob should be freely movable. That is important. Confirm that the advancer knob and burr move freely over the wire. There is the entire procedure of rotation atherectomy is difficult to explain in a talk like this, but I am trying to touch the important points which are of considerable importance to reduce the complications. Verify the brake is holding the guide wire while the burr is spinning. So this is also, as I mentioned, this point we have already mentioned. Now, advancing the burr. There is what is called dynagliding, as I said. The dynagliding is something that is done at a relatively lower speed. The normal ablation speed is about 1.5 to 1.6 100,000 per minute. Dynaglide is about 50,000 per minute. What is dynaglide? There is a separate button on the foot switch called the dynaglide. What it does is that it rotates the burr at a relatively low speed, and that is used for either passing the burr antegrade into the coronary artery or while removing it. In fact, many experienced people realize that there is no need of dynaglide when you are actually pushing the burr. Sometimes you may require it when you are trying to take it out, but very rarely you require it when you are pushing the burr into the coronary artery. But if you are forced to do it, when you do it, you need to break it. You need to break the brake. If you don't do that, it will not move on the wire. Therefore, it is important, and if dynagliding is being done, you need to once again hold the wire very carefully and then only break the brake. What are the feedbacks during ablation? The feedbacks could be visual, they could be auditory, they could be tactile. The visual feedbacks are smooth advancement under fluoroscopy, contrast injection to discern lesion contours and borders. Auditory is pitch change relative to resistance encountered by burr. Now, this is something that you will pick up by your experience. If you are pushing the burr a little more forcefully than required, you will have a different pitch will come, and that is a sign that you should stop it at that stage. Come back and try it after a moment. Tactile sensation also is important. When you are passing the rota burr, you will get a certain feel if there is too much of resistance. The moment you find resistance, you need to stop there and give further burring and then only proceed further. All right. So during rotation atherectomy, as I mentioned, 500 ml of heparinized normal saline solution with 5 milligrams of verapamil and 1000 micrograms of nitroglycerin is administered locally through the 3-port with a view to prevent thrombus formation and vascular spasm and avoiding no reflow phenomena. I will tell you some of the important no's while doing rotation atherectomy. Avoid rapid advancement, dottering, or force. Do not do dottering, but there are many operators who do it actually purposefully. They just go in and touch it. I know one very popular American physician who does this, and he says it is absolutely safe. There's a difference of opinion in this regard. Avoid stopping or starting the burr in the lesion. Important point is, do not park the burr in the middle of the lesion. It's very simple, because you are ablating the atheroma, and if you have done only half the job, and if you leave it there, it will produce prolonged ischemia. Therefore, it is always important, start the burr at a relatively normal portion of the vessel and then go across. Try to cross the lesion carefully, and once you reach the distal point, then come back. Do not leave it. Do not park the burr either in the lesion or distal to the lesion. Always come back and park it. And do not adjust the RPMs during ablation. That's a very strict no-no. If you do that, you will not be able to make out where you are doing aggressive burring. So never touch the RPMs while doing the ablation. Avoid the burr to remain in one location while rotating at high speeds. When you are doing the ablation, go there and touch it. Go there and touch it. But do not do, leave it for a long time at a one point of space. Avoid burring in the guiding catheter. Obviously, one should not do that. You only do dynagliding inside the guiding catheter. The actual burring should start only once you enter the coronary artery. And finally, when you think you have finished, finish it with one polishing run, where it means you just go from the top to bottom of the lesion, and that will tell you that there is no RPM drop and that you have done a reasonably clean shaving of the atheroma and that the bed is ready for further dilatation or stent implantation. Very, very, very important point this slide shows. Never allow the burr to touch the distal most portion of the rota wire. You can see here the distal most portion, the spring tip. You should never touch it. If it touches, the burr may actually cut this point, and the wire may just go distally and embolize into the distal part of the coronary artery, and anything can happen. You will have to recross and you will have to put a stent covering that. In fact, I had a particular experience in the very beginning of my experience that probably we went and touched it. Although we did not know when we did it, but we found that the wire was disconnected. It went into the pericardial space peculiarly. That means it must have produced a very minimal perforation. Patient did not develop any sizable pericardial effusion, but interestingly, he developed considerable pericardial pain and pericardial rub. And we in fact published this experience in Indian Heart Journal also way back in 97, 98. And that's an important point, that never touch this. So it is important that this part of the rota wire, the radio opaque part of the rota wire, is located fairly distal to the point where you want to do rotational atherectomy, so that even by mistake you will not touch it. So that's an important point. We have discussed fairly well about rotational atherectomy. Rotational atherectomy has stood the test of time. In fact, what happened was, in between, the Boston Scientific came out with a different version of rotational atherectomy catheter, which was a rapid exchange catheter. Now, what happened with that? There was a very complicated attachment to it, and most of the operators actually damaged many rota catheters while trying to attach it. It happened to me, and in fact, most operators in India, abroad also, have stopped doing rotational atherectomy because of this. So then the company went back after several years, brought back a over-the-wire type of system, which is a conventional system and which is again what is available in India now. And after that, the interest in coronary rotational atherectomy has once again picked up. And today, I believe a good number of cases are being done in India all over the world. And for long calcified lesions, where you think the lesion may not be crossable with a balloon, rotational atherectomy still is the best technique available. Now, having said that, let us look at the other alternative modalities by which you can do angioplasty in calcified coronary arteries. Now, you can see here under modified balloons, it could be a non-compliant balloon. It could be an ultra high pressure balloon, what is called Opian balloon, which has come relatively recently. It could be cutting balloons or scoring balloons, which have been there for some time. Now, let me delve into this quickly and take you through these points. Balloon angioplasty catheters. Standard angioplasty balloons are actually semi-compliant. That means what? It means that as you increase the pressure, the balloon's diameter actually increases. It can be sometimes increasing as much as a 0.5 millimeters. If you put it on the table and increase the pressure, it can go up as much as 0.5 millimeters. Now, that's not good for the coronary arteries inside the coronary artery. So, semi-compliant balloons today are used only occasionally, and maybe it can be used for relatively easily expanding lesions. The nominal diameter for semi-compliant balloons is typically at 6 to 10 atmospheres. At a relatively low atmospheric pressure, this nominal diameter is reached for the semi-compliant balloons. At higher pressures, if you go, the diameter continues to increase and the force may not be applied equally, what is called dog boning. This dog boning is a word that will come repeatedly in this. What is a dog bone? A dog likes to lick a bone. At the ends of each, the bone is swollen up, and in the center it is thinner. Now, dog boning is typically used in the context of a balloon, which is a semi-compliant balloon, which is inside the coronary, a calcified lesion in the coronary artery. Now, what happens is, because of the excessive atheroma and calcification, the balloon may expand at the edges as the pressure increases, but not in the center. So it looks like a dog boning. Now, the disadvantage with this is that the proximal and distal ends of the balloon, which are expanded compared to the central portion, but these two ends are actually in the relatively normal portions of the coronary artery, and they can produce dissection. That is the big problem of semi-compliant balloons. The non-compliant balloons are called non-compliant balloons, but actually they are also not really non-compliant balloons. They are kind of less compliant balloons, but they are not as compliant as semi-compliant balloons. Even they increase slightly in their diameter when you go to higher pressures. That is the reason why people have come out with better and better balloons. The non-compliant balloons increase relatively less in diameter as the pressure is increased, but the conventional NC balloons, what we call, at high pressures may cause dog boning also due to their uncontrolled growth, and conventional NC balloon do not offer a true non-compliant behavior. Now, let us see now one thing called cutting balloon. There are multiple things in this. The NC balloons have been there for a long time, and as I said, that NC balloons are not completely devoid of compliance. They are relatively less compliant, but they still suffer from this, and therefore all these problems can occur. What is a cutting balloon? Cutting balloon has been there for some time, and basically this is a baby of Boston Scientific. The catheter platform that is used for a cutting balloon is a Maverick balloon. Maverick has been there for a long time, and it is a favorite balloon of many operators. It has got a relatively low profile, it moves very easily, and it's a very operator friendly balloon. Now, they have attached in a cutting balloon modification 3 or 4 or 2 blades on the surface of the Maverick balloon, and these are called atherotomes, which are basically microsurgical blades with flex points. When this balloon is just opened from the factory, you will not feel these blades. Only when the balloon is expanded, these blades will come out and give a neat cut in the atheroma. It is mounted there, as I said, they are mounted on a non-compliant balloon, nylon made balloon. This is called a flextome cutting balloon. This cutting balloon, otherwise called flextome by the Boston Scientific product. Now, flextome cutting balloon is made of nylon material. It's predictable and consistent dilatation, secure fixation of the flexible atherotomes. Diameter could be 2 to 4 millimeters. Lengths are 6, 10, and 15 millimeters, and so on. Now you can see here, to make this blade more flexible, there are cuts given here, and so there are actually points where they are attached, and that will allow this blade to be more flexible, and therefore it allows the balloon to go inside. These are of course made from stainless steel and mounted longitudinally along the balloon surface. Flextome cutting balloon, you can see here that if the diameter is 2 to 3.25 millimeters, there are 3 blades on that. If it is 3.5 to 4 millimeters, there are 4 atherotomes on. And you can see here, sometimes a cutting balloon in a relatively small vessel like this, small and calcified vessel, the cutting balloon itself may be just enough. It may give a good result. It gives a very clean result, rarely associated with the dissection, and perforation also is very uncommon. And you can see further down the slides that for a small vessel, a cutting balloon may be all that is required, and it may give a very good lasting result. You may not require to put a stent depending on the diameter of the vessel. Now, the very important point to be mentioned is the ostium of a coronary artery. Be it you may have to use this cutting balloon for the ostium of say right coronary artery or the ostium of the left main, and here you see the ostium of the left circumflex. Now, in lesions like this, wherever there is an ostium, there is a preponderance of circumferential circular muscle bundles, and therefore, POBA or just doing a routine balloon dilatation may not help at all. You may put a stent, the stent may open, but sometimes because of these circular muscle fibers, the stent itself may recoil, and you may develop significant restenosis at this point. So many operators prefer using a cutting balloon at this point, and therefore it gives better bed preparation for putting a stent. An important point to remember here is that you need to do it with great caution. In an acute angle like this, it may be okay. The diameter of the cutting balloon should not exceed that of the distal reference vessel diameter. Don't size it to the left main or a proximal portion. Size it to the distal vessel and do carefully at a relatively low pressure. That will prevent elastic recoil, and more plaque compression can occur with minimal plaque shift and less vessel stretching, and maximizes lumen gain, and importantly it will prevent the stent from recoiling. And for lesions like this, a diagonal ostium, you may not like to stent, but a routine balloon may not help. You may consider doing a cutting balloon for this point. Now, what about the angiosculpt balloon? Now, what is an angiosculpt balloon? While a cutting balloon actually has blades on its surface, straight ones, the angiosculpt scoring balloon, these are called scoring balloons. It is a PTCA balloon catheter with a nitinol scoring element of 3 spiral wires that wrap around the balloon. Now you can see that here, and they have been approved in 2007, and they have been there for a long time. You can see here that these wires are going around the balloon. This is in the pre-inflation position, and post-inflation it is like this. And the surface of the cutters on a cutting balloon are very sharp, and they give clean, neat cuts, while here these are relatively flat surfaced. So the cuts that are given in the atheroma are relatively wider, probably increases the chances of perforation and complications. Flextome cutting balloon versus the angiosculpt device. Flextome device, as I said, gives a clean cut. Cutting surface of the angiosculpt device is flat versus the sharp cutting surface of the flextome cutting balloon. The flextome, where there are blades, it gives sharp cuts. Here it gives relatively blunt cuts. Cutting balloon device scores the plaque, creates controlled incision planes which help to relieve the hoop stress. What is hoop stress? The stress that is there on the surface of the atheroma. It's not easy to explain in a short time, but basically there is a certain stress created on the atheroma surface, and merely dilating it with a balloon may not help. You may have to give a cut. By giving it a cut, it will actually reduce the need to go to higher pressures. So it allows dilatation at lower pressures. That's an important point. So you can see here a cutting balloon device that has severed the elastic and fibrotic continuity of the vessel wall and has given a neat cut, and therefore it allows the balloon to expand at a lower pressure and open the vessel. You can see here in this OCT picture, after one incision with flextome cutting balloon, you can see these cuts, and after 2 inflation, you can see further cuts. And these are the OCT images of scoring balloon, angiosculpt. As I said earlier, these are not neat cuts in that sense. They're relatively blunt cuts. And you can see after 2 inflations, there are further cuts in this. And cutting balloon device, for you, it provides the rate of device perforation from the pilot study. And the perforation chances in this study were very low, 0.8%. I had an experience of losing a patient actually after using a cutting balloon. Unfortunately, the patient's atheroma was calcified, and quite a huge plaque burden was there at the ostium of the left circumflex. The angle probably was not extremely suitable for a cutting balloon. Whatever the reason, once we dilated that, we produced a perforation of the vessel, and no matter what we did, we lost her. So I just want to say that cutting balloon is a good idea to use in straight vessels where you do not have bends. And if you have a bend or a bifurcation, it should be relatively at a narrow angle. In such situations, cutting balloon is a safe thing. Important to size the cutting balloon. Never go overboard in sizing the cutting balloon, and never go overboard in inflating while doing it. It should inflate at a relatively low pressure. If it is not inflating, probably that cutting balloon is not going to work. Now, angiosculpt scoring balloon, you can see once again here the cuts that are given by the angiosculpt at various points, and dissection-like images inside the atheroma. Okay. Once again here, in the angiosculpt balloon pivotal study, the post-angioscore dissection rate was 13.6% of lesions. And there were no device-related perforations. Because it is a relatively blunt wire, the cuts given are very rarely they will produce perforations. That's an important point to remember. There is not too much of experience with the angiosculpt. They're relatively, people use them less often, and you do not have so much of data as you have in cutting balloons. You can see here some of the differences between cutting balloon and scoring balloon. You can see here the blades are attached straight here on a cutting balloon, and here the wires go around the balloon, and these are the cuts which are given in this cutting balloon. In the OCT pictures, you can see sharp cuts here, and here relatively blunt cuts with the angiosculpt. Now, a great advance which has come in recent, let us say 2 years or 2.5 years, this OPN balloon is available in India. It has been brought by Transluminoid to Indian market. OPN balloon is a balloon that is completely different from the usual balloons. It has got 2 layers of balloon material. So what happens is that the balloon material is double layered, and because of its double layer, the profile of the balloon increases. That is understandable. But what is more important is this balloon, OPN balloon, can withstand very high pressures. Normally, your rated burst pressure for most of the balloons is around 16 or 12 or 18 or so. And actually, the balloon may perforate beyond 24, 26, 28 in cases of NC balloon. But here, this OPN balloon withstands pressures as high as 45 or even 50. Therefore, this is a very ideal balloon for doing calcified lesions. Calcified lesions where there is a huge atheroma volume and calcification. No matter what you do with your NC balloons, you may not be able to open that. Of course, rotational atherectomy is another thing. You can keep it aside for the time being. But if you are looking at a balloon, then the OPN balloon is a very good idea. Now, its entry profile is 0.016, comparable to standard dilatation catheters. The profile is slightly higher than the conventional dilatation catheters. There is a double layer for double power, unique balloon in balloon technology to withstand high pressures. There is an increased tensile strength. Rarely this balloon will burst at even 40, 45 atmospheres of pressure. And what it does, you can see in this beautiful illustration, you can see this center of this balloon having a dog bone effect like that is coming. Like picture is coming, it is holding on to that, but going to the higher pressure, it has opened the calcified atheroma. And you can see here that post-stent, there is a beautiful result. And it is important to look at it is once more that at higher pressure than at 40 atmospheres, it has opened up. So until you reached 40, it wouldn't open, but at 40, it opened. And perforation is not a very serious occurrence in OPN balloon because of its very construction, and therefore it is fairly safe technology to use. You can see here that maximal lumen area here is 12.69. This is at a point where it is not lowest. Probably at this point the calcium is not so much. You can see minimal stent area is maximal lumen proximal reference is 11.9. So stent expansion index is 0.76, which is very good. What is stent expansion index? The minimal lumen area inside the stent divided by the average of the proximal reference area and the distal reference area. That means narrowest area divided by the average area, which is of the reference vessel. That shows that if it is more than 0.6, it is a very good result. And you can see here it is 0.761. Now there is a comparison trial that has been done with ISAR Calc trial, which is done from German Heart Center, published some time back. And here this is compared to OPN NC balloon is compared to a standard NC balloon. Now look at the data. High tensile strength to withstand ultra high pressures, highly rated burst pressure of 35 atmospheres, uniform expansion and controlled growth, true non-compliant behavior, no dog boning, safety at such pressures. Initially, people were not willing to believe that coronary arteries can withstand such high pressures, but experience has proven that they do withstand this high pressure. OPN NC shows less than 10% growth even at high pressures as high as 40 atmosphere. OPN NC achieves this linear compliance due to unique balloon material and innovative dual layer technology. You can see here, even when the pressures have gone up to 40, the diameter increase is relatively minimal. You can see here in the center, this is being compared to other standard NC balloons, and you can see here that rated burst pressure is 35, which is considerably higher than that of the standard RBP of the conventional NC balloons. So a comparison of OPN NC balloon to rotablator to cutting balloons. Here you can see that OPN NC balloon, it is easy to use. It's just like putting another balloon. Sometimes because of its profile, you may not be able to pass an OPNNC balloon, but you may have to use a relatively smaller diameter standard conventional NC balloon, make way for the OPNNC. But apart from that, there is no great learning curve. Procedural time is less, contrast usage is less. It is suitable for treating all kinds of calcified lesions and enhanced safety with lesser rates of vessel entrapment. Acute gain is good. Rotablator, on the other hand, you know that rota is one procedure where the relatively younger doctors or those who have less experience with rota are rather concerned. Rota has a lot of learning curve. It may not be possible to use for everybody in every setup. It takes a longer procedural time, definitely, and considerably higher amount of contrast and so on and so forth. But even saying all this, for a long calcified lesion, probably rotablator is one of the best devices even today. Tips and tricks of OPNNC is avoid polymer wires. Use a standard wire. Don't use these polymer wires like Fielder XT or Whisper. For accessing distal lesions, use extra support guide wires like Grand Slam. For pre-dilatation, sometimes you may need it. Use a 0.5 millimeter lesser diameter balloon than the reference vessel diameter. For post-dilatation, of course, you can use the OPNNC balloon. And you can see in this high-speed rotational atherectomy versus modified balloons. This, of course, in this OPNNC is not included. This is a rotational atherectomy comparison with the modified balloons, which I mentioned earlier. The success rate of rotablator is significantly higher, 19% greater. And you can see here that the same point, the success rate is greater with rotational atherectomy, but there is a considerable crossover with the modified balloons. 16% of them required rotational atherectomy because the balloon could not open up the lesion, and that's an important point. So the reasons for not able to cross with modified balloons is the balloon could not cross and not crossable by modified balloon or any balloon, not adequately dilatable, stent is not deliverable. With rota, these are relatively rare problems. I'm coming to the end of my talk, and I will speak to you about these calcified lesions. One more recent innovation, once again, that has come from, that has been brought into India by Translumina, that is called shockwave lithoplasty, challenging the calcium made shockingly easy. That's what their unique selling proposition, USP, is. And now you can see that lithotripsy has been there for a long time. 25 years of safety data is there in kidney stone treatment. Now, this technique involves a certain technology that will produce ultrasonic waves and that will produce and break the calcium. Now, what is that? Let's see. This is a called shockwave C2, because in this balloon there are two pointers emit energy that will do what we want it to do, and that's why it's called shockwave C2. Now, how this is called IVL catheter, intravascular lithoplasty catheter, and you can see that there is a balloon here, and inside this balloon there are two emitters. Now, what it does, you fill it up with saline and contrast this balloon, and when you emit the energy, the entire content of it gets vaporized. Now that vapor becomes a bubble, and the bubble will burst, and when the bubble bursts, it will produce high atmosphere pressure, and it will actually produce ultrasonic waves that will break the calcium. A lot of data has come in this, and this is basically from England. This technology has come. Dr. Jonathan Swift is the author of this idea, and it creates a short burst of sonic pressure waves, which can go as high as 50 atmospheres. The emitters along the length of the device create a localized field effect within the vessel to fracture the both intimal and medial calcium. All right. Now, you can see here a small cartoon of how it happens, and this is called the technology All right, that's a good way of demonstrating it. And I think you have already seen all this, and no need to go back into this. And what is important here is that you can see this particular picture, and you can see here at while this is going on, you can slowly see that the balloon expands while at the same pressure and gives a beautiful result what you have it here. So at the relatively early part of the IVL therapy, the narrowing is holding, and at the later part it opens up, indicating that the calcium has been broken and the lesion becomes more compliant. And I think one important study that should be mentioned is the Disrupt CAD3 study. This is a very recent publication, I think a few weeks back, and you can see here that I think this was presented at TCT. And you can see here they tried this particular technology in heavily calcified de novo coronary lesions, reference vessel diameter 2.5 to 4 millimeters, stenosis more than 50%, lesion length less than 40 millimeters, and so on. And they did the OCT at the beginning and did the IVL therapy, completed the procedure, and again did the OCT, and look at the results. Now, the primary safety endpoint is like any other case: a cardiac death, myocardial infarction, target vessel revascularization. Effectiveness is successful stent delivery with residual stenosis less than 50%, and the other standard secondary risk factors. And what is important here in the inclusion criteria is that angiographic radio opacities are there before contrast, involving both sides of the arterial wall, with total calcium length of more than 15 millimeters, or presence of more than 270 degrees of calcium on at least one cross section by IVUS or OCT, indicating vessels which are severely calcified. And exclusion criteria are renal failure and recent MI. And of course, these are standard features of any interventional study. And LAD was 50%, and LCA 12, and RCA 29, and so on. Calcium length on an average was about 47.9 millimeters, and severe calcification was there in 100% of the cases. And IVL catheters 1.2 were used per patient. Pre-dilatation was done in 55% of the patients, and post-dilatation was done in only 20% of the patients, and post-end dilatation was done in 99%. And you can see here that pre-procedure, post-IVL, final instant, the diameter stenosis has significantly come down. Post-IVL itself, there is a significant improvement in the diameter, and of course, after stent, there is a very little residual stenosis. So let me come to the end of this talk. And this particular trial has shown very low complication rate and very acceptable results. Composite success rate was more than 90%. Device crossing angiographic success with residual stenosis less than 30%, and so on. So let me conclude this talk by saying that the presence of coronary calcium is a big challenge for the interventional cardiologist. The presence of coronary calcium can prevent the balloon from expanding adequately, and from the stent from being delivered there, and the stent may not expand. For all these reasons, one has to have a variety of techniques available in case you need them. It is always preferable to plan one of these techniques. If at the time of angiography, diagnostic angiography, one should be mentally prepared which case is likely to have more dense calcium, and it is preferable in all these cases to have a pre-procedure, pre-stent OCT or IVUS to study this, and depending on the degree of calcium, decide one of the techniques. You can see here that this is a slide that shows how you should go about it. If it is deep calcium, you will need not the superficial calcium, you will need a scoring balloon or cutting balloon. This is from the OCT images. If it is superficial calcium and you think you will not be able to cross with a balloon, you may have to go for a rotational atherectomy or an orbital atherectomy. If you think balloon crossable lesion, then you may have to go for intravascular lithotripsy. Any one of the variety of techniques should be available, and one should familiarize himself or herself with one of these techniques, and then probably most cases will come out successfully even when the vessel is densely calcified. Thank you very much.